Okay, we're going to get rolling here. So again, thank you all for your time. My name is Ernie Wallerstein. I'm one of the co-founders and the CEO of Mental Health Technologies. And the topic for today's webinar is automating behavioral health screening to improve clinical care and revenue. And this is especially tailored for urgent care environments. So appreciate all your time. If you have any questions during the presentation, there's a Q&A button on your screen. Just click in there, type your question in. Alyssa, who's from our organization, will be moderating that. At the end of the presentation, we're trying to leave plenty of time for Q&A and actually hoping there's a lot of exchange during that time. And if we need to dig deeper in our conversation, might unmute someone and ask them for further clarification. So we'll do the presentation, plenty of Q&A at the end. Any questions, please put it into the Q&A section on the screen, and we'll get to it at the end. So our organization's Mental Health Technologies. We'll get into that as part of this presentation and appreciate everybody showing up here. What we're going to cover in today's webinar is talking about behavioral health and behavioral health screening in an urgent care environment. And the key objectives of this conversation and this presentation is going to be about improving patient care, especially as it relates to behavioral health and overall wellness, creating ancillary revenue in an urgent care environment, eliminating administrative burden. How is this entirely automated? How does this not add work? So while improving clinical care, there has to be a correlation to how much extra effort is involved with that. What are the costs involved with that? What's the revenue opportunity involved with that? We'll cover that during this conversation. How this is entirely customizable. And lastly, if you're in an urgent care environment and someone identifies with a problem at an acuity above maybe the skills or the availability of resources within your practice, how do you get that person to the appropriate resources? And we have both an automated way of doing that, as well as a network of nationally available behavioral health providers that we can introduce you to if you're interested in this type of solution. All right, so that's the overview of what we're going to cover, and we're going to dive right into it. So some high-level numbers. We're not going to spend a ton of time on this. You all live this every day. I'm sure you're familiar with it. But unfortunately, the behavioral health crisis isn't getting any better. It's getting worse. In the short time I've been doing this, which is just about 6 years, I come from the tech side, the number went from 20% to 23% of adults in the U.S. who are afflicted with a mental health illness. And there's two types of mental health illness. There's any mental health illness, and then there's severe mental health illness. And you'll see those terms online when you research this. So at the level of any mental health illness, it's nearly 60 million Americans, or 23% of the adult population in the U.S. that have a challenge. And unfortunately, about 50% of those people go with an undiagnosed or untreated condition. All right, so this large population of people who have an issue, who are seeing healthcare professionals, yet their behavioral health issue goes undiagnosed or untreated. The problem's even bigger with adolescents. The amount of anxiety within our youth population is growing at unfortunately an alarming rate. And this last stat has to do with so many people don't know where to go for a behavioral health issue, an anxiety attack, a high level of stress, sleeping that's based on depression. And 8% of visits, according to a lot of stats online, National Institution of Health, National Institution of Mental Health, 8% of visits to ERs are mental health or behavioral health based. ERs aren't really set up for that. And when people go see their primary care provider or urgent care provider, if there's additional resources there, that can stop these people maybe going from the ER where the right resources aren't there. And also it's a very costly way of trying to deal with a mental health episode or a behavioral health issue. So those are just some dynamics, but let's dive into what we're talking about here. So what we do at Mental Health Technologies is we allow healthcare providers to intelligently screen and test patients for behavioral health issues. And how do we do that? So, we really understand there's not a lot of extra time in an urgent care environment. There's not a lot of extra resources. So how do you do this in an efficient way while providing better clinical care. So, we identify what we understand after talking to several urgent cares and primary cares are key pain points and how we address those. So there's limited time. Administrative staff turns over quite often. Training them is difficult. They're busy. So what we do is we automate the entire process. We integrate with your EMR and we automate the entire screening process. The rules for screening, we have a wizard that we use that we build the rules based on your needs. We work with your medical director, with your principals. They tell us how they want these screens, which screens. We provide expertise in that and provide options, but you tell us exactly how you'd like your patient screened and what screens they get. That is entirely automated because we integrate with your EMR. Whenever there's an appointment or a patient walks in or checks in for an appointment, we get a notification, which we call a trigger, from the EMR, and then based on the attributes of that appointment, what type of appointment, location, insurance information, payer. If it's a self-pay, you might tell us, hey, I don't want to test self-pays because I can't bill that to a payer. Whatever those rules are, payer, location, provider, time of day, type of appointment, all of those rules can be used and based on those rules, make decisions. Our software can make decisions. Should this patient be tested? What test should they get? Or should they not be tested? When that patient's tested, as soon as they're done taking their test, those results are immediately written to the EMR. Your staff does not have to learn another application, another portal. Your admin staff doesn't have to touch MHT. Your providers definitely don't go in MHT. All the results are in your EMR, be that eClinical, Athena, Epic, whatever that EMR is, those results are where you already go to do your encounter notes and where you look at your patient's vitals. They all show up as a lab result in your EMR. The other part that we've learned here is, there's a lot of bilingual people in the United States. So these tests can go out in Spanish, but the results are written in English in your EMR. We've been in a lot of clinics and we noticed that, someone comes over the loudspeaker or the intercom and says, hey, I need a Spanish-speaking admin, a Spanish-speaking nurse to go into, exam room 3. Our software can screen the people in their native language. So as long as that's in your EMR, that they're Spanish, our assessments will go to that person in Spanish. They take those assessments, but your staff can see the results in English. So this has to, make sense. It has to also provide, which is a challenge, in unified, in urgent care, there's, lots of challenges in terms of making profit. Payers continue to squeeze. So this has to be a profitable opportunity. It has to make money, right? So quality of care, number one, efficiency, number two, but it also has to be a revenue generator, a profitability generator. So these tests are billable in a fee-for-service model. There are CPT codes where you do an add-on code with a 59 modifier, and you're able to add that to your E&M code or your E&M procedure and create incremental revenue. And we've done it with many different environments. We know that works in urgent care. We have several urgent cares already doing this. If you happen to be in a value-based model, there are additional codes, HCC codes, and there's other benefits to doing this in a value-based model. And I actually have a slide. We have a slide later here that talks about the benefit in a fee-for-service versus value-based model. Decreased costs. This promotes preventative care. It allows providers to know ahead of time if the patient might be has a comorbid condition that requires attention. So when the patients take a test, if they happen to score high on a test, depression test, anxiety test, social determinants of health, a general wellness test, if they score high or they have a number that's above a threshold, that would be alarming for lack of a better term. We actually note that in the EMR with an abnormal flag, so it stands out. Now your staff, your MA, your PA, NP, or even before your doctor goes in there, they know it. It's part of the conversation. You're not blindsided by it, and you can bring that into the overall care for the patient. So you're increasing your quality of care, but you're also decreasing costs. This is way more efficient. It's time saving, and it's entirely self-administered by the patient. So the patient walks in, at the piece I left off here from limited time. In an urgent care environment especially, our integration to your EMR is absolutely paramount. Because we're integrated to the EMR, as soon as the patient walks in, we know they're there. We can send them the assessments on their cell phone, and they can take it whether in the waiting area. They can be given the assessments on an iPad or a Android device in the exam room. All of that stuff becomes incredibly efficient because of our tight integration to your EMR. The last point here, number 4, is about increased quality scores. So there are measures, and we see them more and more in different states, and with some of our larger customers, we see the need for them to meet certain criteria for different payers. That could be social determinants of health for Medicare, quality of care measures required at a state level. Perhaps for employee-based care, there are requirements necessary for the payer or the organization that's covering those. So this allows for objective measures that are documented to be available in whenever that's needed for a quality of care measure. And all of this stuff, as I mentioned, automated. It's interpreted by your provider. We don't provide the clinical analysis, but we automate this entire process of screening for behavioral health. How does it work? I know this is a busy slide. Just walk through it quickly for the more technically minded folks on this call. The EMR is a starting point. That is your source of truth. We integrate to it. That is your system of record. We're a system of action. Based on what's happening in the EMR, we get the appointment information, we read the different attributes of the appointment, and then our AI engine, which we call Smart Test AI, then runs through a decision tree and ascertains should that patient be tested or not tested, right? Once the patient's tested, those results are immediately written back to the EMR. At the bottom of this screen, you'll see some things in red. There's other things happening in the background that provide additional intelligence and allow you to increase your quality of care for patients. While a patient's taking a test, if they score high for a test, our software can pop up another question for them. That question could be as simple as, would you like to talk to our behavioral health partner? If they say yes to that question, we then automate the referral to the behavioral health partner, which I'll dive to in a little bit more detail here shortly. But that happens automatically. So patient scores a level that you don't have the resources for. We then ask that question. The patient is then consenting, yes, I'd like to contact your behavioral health provider or your partner. When they say yes to that question, when they're done taking their test, we actually redirect them to the URL or landing page with more information about that behavioral health partner. If you don't have your own behavioral health partner, we can introduce you to several large national players that might fit your needs. We don't tell you who to work with. We make introductions, and you decide who the best partner is for you. We try to make intelligent decisions on who we introduce you to. Do they have brick and mortar in your area? Do they cover the vast majority of your payers in your network? So we do our homework and then introduce you to a couple options. Then you tell us who you're comfortable with, and we do these automated redirects to these behavioral health providers. So obviously your provider should know about that. We let them know that in the EMR, that this person was referred. Your providers need to be comfortable with these behavioral health clinics, but at a medical director level, at an executive level, you could say, we want this level of treatment to be ubiquitous across our entire organization, and we help you automate that. If a patient happens to say they're interested in behavioral health, or a patient indicates something that's important to you, we can also send alerts through email or text messages to your staff. You tell us who should get it in this situation, and we send that alert to your patient. Hey, patient just came in, they scored really high on this test, right? You wanted someone to know that ahead of time. We have an urgent care where if patients score above X, they want the medical director, the chief clinician for different locations. And we have a case study at the end of this, I'll share this, but they have like 10 locations, but they have area directors. If someone scores high, they want the area director to know. And we just send a text message to that individual. It lets them know, hey, at some point today, I want to follow up with that provider, make sure we provided the level of care we're looking for. It allows them across the board to raise their quality of care. Lastly, once those results are in your EMR and it's been reviewed, the results get dropped to the encounter note, and we can automate dropping CPT codes or a heads up for your rev cycle team. Hey, this is the level of service was provided. Consider these different CPT codes. So there's a level of automation in the incremental revenue that can be created here. There's several different codes that can be added, and there's different codes which we can provide guidance on. We don't provide directive. We're not a billing company. We're a technology company, but we can provide guidance from our experience and having done 1 million of these tests over hundreds of thousands of patients. We could say, hey, here's what's working for some other clinics. Here's some codes your rev cycle team can try. So that's how the process works. If offline someone wants to dig into this deeper, happy to do it. But at the end of the day, the key here is all of this is automated. Your admin staff, your staff don't have to drive this. At a medical director level, executive level, you could say, this is how we want to handle behavioral health, and we will help you automate that process. So sometimes the question comes up, well, can't my EMR do this? Well, there's certain things an EMR can do, but there's things that we do that an EMR does not do. So assessments being sent to a patient ahead of a visit, well, EMRs can do that. There's companies like Phreesia out there that do that. So we do that based on the attributes. Where things change and what things we can do, and we're very nimble about it versus a lot of EMRs where it takes a lot of time to add change or make any changes. We can tailor the workflow based on your rules. While you're testing, you may have a change of mind in an hour, 30 minutes really, but we typically do it overnight, so it affects the next day's appointments. We can make any changes to the workflow, which assessments they get. You want to add additional wording to the assessment. All of that for us, we have wizards for all that. All of that stuff can happen in under 24 hours. Next business day, those new rules are in place. Automating the referrals. Who gets the referral based on different circumstances? So this is real world for us. If a patient scores high for depression and they're on Blue Cross Blue Shield, that might be referred to a national behavioral health partner. If they're on Medicaid, it might have to go to a state resource. If they're on Medicare, but in a different state, they might have to go to a different behavioral health partner. All of those rules we can automate, and based on those different attributes, make different decisions of where that patient should be redirected, what level of care is available to them. And lastly, we could also identify ancillary services. If you're doing new procedures for preventative care, so a big thing now we see is sleep studies. Patient comes in, they might have different conditions. Pain is a big one, back pain, they're having trouble sleeping. A lot of times depression is a key driver of that. If someone walks in and you're trying to ascertain, hey, is sleep part of the problem? We can provide an assessment for sleep. One of them out there is called Stop Bang, STOPBANG, and that's an acronym. And if the patient scores high, ask them, are they interested in a sleep study? Because your clinic happens to be doing that. You could be doing a pain study, any type of study or type of service, care service you're trying to provide. We can, when it's appropriate, ask questions if they're interested in that. And if they are, we can redirect them to a landing page with more information about that service, and also send an email to your team that's dealing with that. Maybe you have an intake person, you have a specialty team, you might even have in-house behavioral health services. We can redirect it to that team first to see if they can help that patient, and then maybe overflow it to one of these national behavioral health partners. So that's some of the differences. And a key difference too is, we're quick, we're nimble, we're born from a technology standpoint with a high focus on customer care. We know in an urgent care environment, in a healthcare environment, you're getting bombarded with technology. We try to provide you solutions. We become your technology partner. You need change, we make the change. We have customer success reps dedicated to all our customers. We know when you touch something once in a while, you need a report. You don't become an expert at something when you need something once a month. You need a report, we run it for you, and we send you the data in an encrypted file that's password protected, as an example. So a couple different modalities for billing nowadays. Value-based care, as we understand it, is growing in the urgent care environment. There are some value-based networks out there that are trying to get patients to go to urgent cares instead of the ERs or emergency rooms in a hospital because of cost basis. So there's a couple different ways our software works, but I wanted to focus on this point at the bottom first. Our revenue model, MHT, to you, you're our customer. We're not involved in your collections. We're not involved in your billables. We have a rate that we negotiate with you, and we only bill you if you successfully test the patient. If you send out 100 assessments and only 50 patients take it, we're only billing you for the 50 patients that took it, not the 50 who didn't. We only bill you once in a 3-month period. So if the patient happens to come in multiple times, we know you can't bill for it multiple times. So we don't add additional costs. So we're trying to make sure this is in line with your opportunity to create revenue is. But the big key here is only if you successfully test the patient. There's no fixed fee. There's no monthly subscription fee. In fact, if you're interested in our software and using our software, we do a free 30-day trial for up to 250 patients. So you can try this out, get comfortable, make sure it works for your provider, make sure it works for your rev cycle team in terms of your payer mix. We are willing to put skin in the game because we know this really works well. And once 9 times out of 10, if someone trials this, they're going to use it, and to their benefit and to their patient's benefit and their provider benefit. So in a fee-for-service model, there are add-on CPT codes. One of the benefits here is you're going to provide the highest level of care you can. You're bringing behavioral health in, you're integrating, you're automating it, you're making it very consistent. There are objective measures. We have a couple customers who use this for their MIPS requirements. If they're seeing patients in a Medicare environment, or they're in remote areas where there's not a lot of primary care doctors, they are the primary care provider for that patient. Percentage of assessments taken, we have several clients who tell us they actually have objective measure requirements with payers. They need to have 75% of their patients tested or objectively screened. We're hearing overtones that the federal government may start requiring social determinants of health. Now there's a new administration, so we'll have to see how that plays out. But social determinants of health are becoming something much more commonly required. We can automate sending those out to your patients. And all these tasks are set up to save time. Your MAs don't have to touch it. They might review it. Those results are automatically there up on the screen. The referral to behavioral health is there. Referral to ancillary services there. We help automate that process. Now, in a value-based model, it's different. You're not adding CPT codes, but there is HCC coding that helps adjust the RAF score, and that allows for incremental benefit from the payer or from Medicare for caring for that patient. Documentation is typically a requirement in a value-based model. This allows full objective measuring. All the test results are uploaded to the EMR. Identifies at-risk patients. You know, there's a saying there, before stage 4 from the American Psychiatric Association. The earlier you can identify somebody with a behavioral health problem, the much more cost-effective it is to provide care for that individual. And as we mentioned, same thing, it automates the entire process for your staff and leaves them more time to go deal with your patients and save them time from documenting, transcribing things related to behavioral health. What we wanted to share to sort of bring this all together is a case study of where we're already doing this with a large urgent care in the United States. This urgent care happens to be in multiple states. They have clinics in 5 states. They have 10 plus locations, 50 plus providers. We're integrated to their EMR. We're fully integrated to their EMR. And we deal with both a small percentage, about 10 to 15% of their patient appointments are scheduled, but the vast majority are walk-in patients, right? We only know they're coming in once they walk in the door, right? And they're then in the waiting room. But we know that within 1 minute because we're integrated to the EMR. And as soon as they walk in, we get that notice, that trigger from the EMR. So what was their challenge? They had a very large percentage of patients that were coming in where there was either a comorbid or a principal issue that was behavioral health related. And they just didn't have the bandwidth to deal with it. and it was very hard to make it cost justifiable to deal with those issues. It was becoming a financial burden to them. So we worked with them. They did a trial. We built a great relationship with them, and we implemented Smart Test AI, the name of our product, to screen patients on a whole bunch of parameters. They have a big payer mix. They do have Medicaid and Medicare patients. We differentiated new patients for what the baseline testing was. We also made some different rules based on location. Some of the behavioral health providers were available in one state, but not another state. We flagged high-risk patients right away. They were very interested in understanding if someone's at risk. High depression score, high anxiety score, drug and alcohol scores. If someone was at risk, they wanted the medical director for that location to know, as well as the provider. So we set up alerts for that. We introduced them to a couple different behavioral health providers, and they actually have a mix. In one state, they're using one of the companies we introduced them to. In another state, they're using a different one. And then for Medicaid, they are redirecting to state resources. Unfortunately, some behavioral health providers take Medicaid, some don't. So instead of burdening your patients to figure this out, we can make business rules and automate the process of what options are available to them. So we've done that for this clinic. We track progress on repeat patients. If they have a patient come in, they want to know, is that patient getting care? Are they getting better? What's happening at a demographic level? So every month they get a report from us and say, hey, here's your average test score. Here's how you're banding against other primary cares that we deal with. And overall, your patients are improving or not improving. Luckily, their patients are improving. Their staff is getting way more efficient with dealing with these situations. And they're ready for that behavioral health conversation because we give them an alert ahead of time. We've worked closely with their rev cycle team. Like many urgent cares, they have a small in-house team, and then they outsource their rev cycle information. So they've been running reports. They meet with us, what works, what doesn't work, and we help them automate which codes, when they review that encounter, the potential CPT codes based on the parameters of that visit. So it's been very beneficial for them. So the benefits for them have been their staff have been able to focus much more on the patient. They've been really happy with that. They've been happy with their entire staff being involved in this initiative of providing better overall wellness for the patient population. They're averaging about a $20 per tested patient of incremental revenue. And that in just the month of December, that was an additional $50,000 of profit to them. So after the costs were involved, paying for MHT, the rev cycle stuff, it was a $50,000 benefit. Now, to a lot of urgent care environments, that is good, positive, incremental revenue. And if you do the math there, it's almost $1,000 per provider of additional profit while providing better care. So it's, the perfect mix of two worlds there. And they don't have people administrating this as an automated, fully integrated with the EMR. Interestingly, when a patient scores above X, so if they score above a 12 on a PHQ-9, which is a depression screen, or a 10 on a G87, which is an anxiety screen, we automatically ask at their direction, is this patient interested in talking to a behavioral health provider? 35% of the time, more than 1/3 of the patients who score above that score say yes to that question. There's a lot of people there who've been struggling for a long time. They're looking for help. So, a lot of urgent cares have lots of remote locations. This allows them to ubiquitously offer that better level of service. And then those patients are, in an automatic fashion, they're introduced to that behavioral health partner. And that's all working for these folks. And it's been a great relationship, and it's been a profit center for them. And again, while increasing quality of care. So, that took about 30 minutes, which was my goal. What we'd like to do is to get some Q&A. I'm just going to take a quick look here, make sure I covered all the key points, but I believe we have, and would love to do some Q&A. Alyssa is going to share some of the Q&A questions with me. She's going to tell me what the question was, and I'm going to try to respond to that question.
Ernie, we have a question from Margaret O. She asked, when you note EMR integration, do you mean discrete integration of a measure score, or is there a PDF generated with those results, and does this differ between different EMRs?
Great question. So when we integrate to the EMR, we're actually integrating at a pretty low level. The EMR is sending us data about every appointment in the EMR, and then we read the information from that. When a patient takes the test, we send back to the EMR 2 data points. We send a summary of the test. So this patient took a PHQ-9 and scored 12, X, but let's say 15, right? We put that in there. If that is above the threshold that you want to consider abnormal, we will put an abnormal flag. Most EMRs, when you put an abnormal flag on, they'll put that result in red. We also then send a PDF that's attached as a lab and a document. We send that to the EMR, and that has the full representation of every question and every answer from that specific patient. So to answer Margaret's question, we deal with every EMR pretty much the same way. We integrate to them differently. EMRs have different APIs for integrating. That does not become your problem. We deal with that. Luckily, the vast in the back room, including we come from the technology world. So we normalize all that for you. So if your EMR is eClinicalWorks, it's Athena, whatever it is, we normalize that. We've already integrated the 6 EMRs. We have published APIs that we use, and that's not your problem. You basically open up a ticket with your EMR, and we take over that project for you. So after you've done your trial, you say, hey, I think this is great. We then really become your project manager for the EMR integration. We know that's a lot of urgent cares don't have those resources, or they're working on other projects. We take that on, but you basically just open up a case with your EMR. So more succinctly, Margaret, how the MHT results work is very similar EMR to EMR. We normalize all that, even though the integration might be different technically for different EMRs. And yes, the PDF is attached with what we call, for all intent and purposes, like a lab result. The EMR is there with all the individual questions and what that specific patient responded with.
Another question from John R. How do you integrate your screening questions with additional questionnaires to avoid having patients complete 2 separate screenings?
Yeah, so that's a very good question. We have customers who use Phreesia, and what you don't want to do is create patient fatigue. So we learn that with you. We do consultation with you. We make sure we're not overlapping with existing questionnaires that are going out. What a lot of our clients have done is they have intake documentation that goes out through their EMR or through a third party. We might not test patients on the first visit. It's subsequent visits that will test patients so they can integrate a lot more behavioral health information, behavioral health screens, and get a bigger picture from a clinical perspective for their patients. Our algorithms also are set up that if a patient gets tested, we know what kind of appointment type it was. And we also know if the patient's been tested before. So you may say, you have the ability to say, okay, I want to screen this patient for depression, anxiety the first time. And we're actually doing this for that case study. If the patient scored high, the next time they come in, they'll test them again for depression, anxiety. If they did not score high, they might screen them for drug and alcohol. If they screen both of those within 1 year and nothing was alarming, they won't test that patient again until 1 full year has passed from their prior test. They might have 5 appointments in between now and then, but our software is saying, okay, if they scored above X and already took this test, don't test them again unless it's a year later, based on medical necessity or what screening requirements that medical director wants to provide their patient population.
Another question, is there an opportunity to use this outside of an appointment or at a clinic that only takes appointments?
So yes. So if a patient does a walk-in or a patient schedules, you need to televisit within. So let me answer that separately. So yes, we could do it in an environment with appointments. We have non-urgent cares who use our software. We actually have behavioral health providers. We have a spine clinic who uses our software. We have a primary care, large primary care. It's all appointment based. In that case, we get the appointment information ahead of time. And we can actually send assessments out to the patient the evening before their appointment, the morning of their appointment. So we can schedule when it goes out when it's not a walk-in environment. If it is a walk-in environment, as soon as that patient walks in, we run through our algorithm, and 1 minute later, we ascertain should that patient be tested or not. And then an assessment link is sent to that patient's email or mobile, or the patient can take that assessment on an iPad kiosk in the waiting room. So both of those environments work. And especially in an urgent care, that walk-in environment, it's almost impossible to do this screening without integration to the EMR, because you need those results uploaded to the EMR basically instantaneously, and we're able to do that. Plus, you instantaneously need to decide, should this patient be tested? Otherwise, you're doing it on paper. There's a lot of work to be done. People have to transcribe it. So we get that out of there. So both of those environments work. I hope that answered the question.
Another question from Bob M. Which EMRs do you have established integrations with?
Sure. So we have completed eClinicalWorks, InSync, Advanced MD. We've done all the preliminary work on Athena. We're going to execute that here shortly. There's two other ones that aren't popping off the top of my head. So we've completed 5. One is principally done. And, the big one we haven't done yet, but it's not, is just Epic. We just haven't had a client ask for Epic. We're actually waiting to do that. We know how to do it. So basically, there's not a lot. The only EMRs we'd ever have a problem integrating with are ones that don't support standard APIs, which are typically HL7 or REST APIs.
Another question from Bernie. How about utilization with occupational medication or work comp patient population?
Sure. So if in your EMR, that is an appointment type, workers' comp, for example, or occupational, and you want those patients to be tested, you tell us, based on that appointment type, which battery of assessments. We have about 60 different assessments. We also have a wizard for adding assessments. So based on that appointment type, we can, based on your medical director's direction, say this patient as part of that appointment should get these assessments. And sometimes workers' comp is a capitated cost, but you need objective measures. You give us that direction. That for us just looks like a different appointment type, so it might require different rules, but we can make decisions based on any type of appointment. We can read that, and then from that make a decision of should this patient be tested and what test should they get. And or the workers' comp could also be a payer type, be it appointment type or payer type. We can make decisions based on either one of those attributes.
And another question, how do you handle circumstances that are outside of our skill set? So we may have some behavioral health capabilities in-house, but how do we handle some of that overflow?
Yeah, those are a great question. So a couple different ways to do that. If the score on a behavioral health screen, and look, it's a screen, it doesn't tell you the entire story. There are much more clinical, there's much more that a doctor, a nurse, or PA or MA would learn by talking to a patient. But these are standard screens. They're highly efficient. If someone scores within one band, let's say 10 to 15, you may send that to your internal team, right? And we would redirect that patient to your internal team. We'd let them know, hey, there's a patient with a behavioral health issue within that banding, for lack of a better term. If it's above that, you may want to say, hey, you know what? That's probably outside of our skill set. Let's ask them if they'd like to be referred to our behavioral health partner. The other way to do it is an overflow. Everyone goes to your internal team. If you have that bandwidth, they ascertain if it's within their skill set or not. But we can automate either one of those rules. You may want to triage internally first before you outsource, or you may want to set up a couple different banding levels and then make a decision based on those test scores. Do we keep it internal? Does it go external? A lot of urgent cares have the ability to handle, tier 1, tier 2 behavioral health issues. It's when it goes outside of that, if you're going to automate this screening, that you want to have an efficient and consistent option for your patients that might be outside the skill set that you have in-house at the time.
And just a couple more questions. Another one is, how do we handle our self-pay patients?
Great. Excellent. Appreciate that. So self-pay typically the payer, and you will tell us if you want those patients tested or not. And so if your self-pay is a high percentage of your patient population, you may say, hey, look, I'd love to be providing this level of service, but we can't charge them. We have one clinic that actually, for their self-pays, comes in, it's a decent percentage of their patient population. They tell the patient up front that there's an additional cost for doing this. We have another clinic that says, don't test my self-pays. You tell us what the rule is that you want to use, and it's going to have something to do with your payer mix and your size of your self-pay population, if you want them to be screened or not. And we can screen them and give them a heads up that, hey, there is a charge for this. We can screen them with no heads up if that's what you prefer, because it's a small percentage of your patient population, or we cannot test them at all because it becomes a challenge for you to deal with it from a billing perspective. We can read self-pays, and then based on what you tell us the rules are, our software, our workflows will make decisions if that patient should or should not be tested.
And then one last question, who pays for your service?
So our customer is the healthcare clinic. The urgent care clinic is our customer. So we have a rate that's based on successfully tested patients over a 3-month period. If you test them more than that, we don't charge you again for that patient. We only charge you for successfully tested patients. We have a rate that we know is typically beneficial and allows you to make at least a 200% margin. If for some reason the state you're in, your payer mix, your reimbursement is, below that $20 line that we see as an average, then we'll negotiate our rate with us. We make sure this is a profitable service you're providing while increasing clinical care. But to answer that question more succinctly, you're our customer, the urgent care clinic, based on this audience, or the healthcare clinic, you're our customer. We do not get involved in your individual rev cycles. We work with your rev cycle and make sure they're successful with this, but we're not part of that. And of course, based on Stark laws, we have nothing to do with the referral. So if we introduce you to a behavioral health partner, that's just part of the service. We know it's needed. There has to be a place to send patients that need the care, but we have nothing to do, or any reimbursement has to do with referrals. It's also against Stark laws, but that's also not how we're set up. Is that it, Alyssa?
Yep, those were all the questions.
So I want to thank everybody for all the time they spend with us. Hopefully you found this interesting. We know behavioral health is a growing issue. It's important to urgent cares to provide that. Urgent cares are first line of defense for lots of people in this country. And we believe we can help you deal with that growing problem and making it financially beneficial while also making it clinically beneficial for you to provide this level of service. If you need any more information from us, the information's been on the screen for a while. We'd be happy to get in touch with you, happy to demonstrate this to you. And again, if you're really interested, we do live we provide free trials of our software prior to the integration, so this is going to work in your environment. Thank you, everybody. Appreciate your time. We know everybody's busy, and everybody stay warm out there. Thanks.